We'll get started in just a few moments. Welcome, everyone. Thanks for making the time to be with us today. We're going to get started in just a moment. Well, hi, everyone, and welcome. I'm Michael Morella, Managing Editor at U.S. News and World Report. In today's webinar, we're exploring innovations in children's heart health and sharing lessons for pediatric leaders. Today's session is part of our ongoing Healthcare of Tomorrow virtual event series. You can learn more about our speakers and some other sessions we have coming up later this year at usnews.com/healthcareoftomorrow. We are recording video of today's program as well as simulcasting on the U.S. News Facebook, LinkedIn, and YouTube channels. To those of you watching live, if you have questions, we ask that you please type them into the Q&A feature on your screen. Our team will review and our moderator will try to give voice to some of those as our time allows. Now I'd like to welcome our panel. With us today are Dr. Nikhil Chinani, Medical Director of Quality and Outcomes at the Children's Healthcare of Atlanta Heart Center, and a staff cardiac intensivist at Children's Healthcare of Atlanta. Dr. Ann Dubin, Chief of the Division of Pediatric Cardiology and Director of the Betty Irene Moore Children's Heart Center at Lucile Packard Children's Hospital, Stanford, and Stanford Medicine Children's Health. Dr. Eve Dudicum, Division Chief of Cardiac Surgery and Co-Director of the Children's National Heart Institute. And Dr. Kayla Lopez, Associate Professor of Pediatrics in the Division of Pediatric Cardiology and Director of the Pediatric Cardiology Transition Program at Texas Children's Hospital and Baylor College of Medicine. Welcome to you all, and thank you for making the time to join us today. Now I'll turn it over to my colleague, Shanley Chen, Senior Health Editor at U.S. News, for our panel discussion. Shanley?
Thank you, Michael. The field of pediatrics is an integral part of a young individual's health that has profound effects on the trajectory of their lives. From the moment they're born to the time they transition into adulthood, pediatric healthcare providers shape the health and development of all children. Pediatric cardiologists are at the heart of it all. We're joined today by 4 of our nation's leading experts in the field of pediatric cardiology to discuss the effects of the COVID-19 pandemic on children's heart health and the workforce, cutting-edge research and innovation, health disparities that continue to plague underserved communities, and much more. I'm excited to have our distinguished speakers share their knowledge and insight about these topics. But before we get started, I'd like to allow each of them to briefly introduce themselves. Dr. Chinani, would you like to kick us off? You're on mute, Dr. Chinani.
Thank you. It wouldn't be a Zoom meeting without a mute error. Anyway, thanks, Shanley. I'm Nikhil Chinani. I'm actually one of the cardiac intensive care doctors in Atlanta at Children's Healthcare of Atlanta. And along with clinical medicine, a lot of my work is around what we can do as a system and as a heart center to take better care of these children and to help shepherd them through from fetus all the way through adult life and what we as a system can do better each time. So I'm really excited to be here. It's a really great group and we really appreciate what you guys are doing. Thank you.
Thank you, Dr. Chinani. Dr. Dubin.
I'm Ann Dubin. I apologize in advance for my voice. I am one of the sufferers of the recent RSV/flu/COVID group. I am the division chief for pediatric cardiology here at Stanford, and I oversee a group of 71 pediatric cardiologists in our division. I am also the director of the Betty Irene Moore Children's Heart Center at Stanford, at LPCH Stanford, where we have over 300 physicians, nurses, respiratory therapists, you name it, in cardiology, CT surgery, anesthesia, and imaging. My area of interest is in pediatric electrophysiology or arrhythmia management. And I have really kind of spent my career looking at the intersection between arrhythmias and heart failure. And really where I do most of my work is in an area called cardiac resynchronization therapy, which is a powerful tool for helping children with heart failure.
Excellent. Thank you, Dr. Dubin. We can't wait to learn more about that. Dr. Dudicum.
I'm a pediatric cardiac surgeon, and I'm probably one of the few people who have been trained and worked on 4 different continents. So I think for an audience of the US News and World Report, that may be of interest. I had a successful career mainly in Australia for 17 years. And then for the last 10, 15 years of my professional career, I thought that there were things that I wanted to achieve and innovation I wanted to see in the field. And I wanted to prove myself whether I had some leadership of my field. So what better place than North America to do so, and what better place than Washington, D.C. So here I am, and I've been here for 2 years now.
Excellent. Thank you, Dr. Dudicum. And finally, Dr. Lopez.
Good afternoon. So my name is Kayla Lopez. I am a pediatric cardiologist who is an imager. So I image in fetal life, TEEs in the operating room, etc. I also am a health disparities researcher, and I always call myself a public health person who happens to be a pediatric cardiologist. And so a lot of the work that I do has to do with access to care, social determinants of health, and upstream issues that affect downstream healthcare and health disparities. Thank you for the opportunity to be here.
Thank you. And thank you, everyone. Let's dive right in, starting with COVID. The pandemic has had far-reaching consequences and ripple effects that have undoubtedly affected our health. From mental health issues to long COVID, we're still working on uncovering the true magnitude of its impact. In your field, how has the pandemic impacted children's heart health specifically?
I guess I can jump in. I didn't know, Shanley, if you want us just to bounce around a little bit. You know, I think early on, we felt fairly lucky in cardiology. I think our patients were generally not as impacted as we were seeing in adults, adult cardiology or adult heart failure. Pediatrics were relatively protected. But I think what most of us really felt was how it impacted our staff and our hospitals. And I think that's where a lot of what we started to see, that confluence between delivering patient care and being able to have the staff to deliver that patient care sort of came into play. And I think, you know, every hospital handled this differently. And we started to talk about things about how it impacted nurses. And, you know, families really felt that. Because I think a lot of what makes a great health center great is those relationships and how our staff were being stressed. You could see that impacting our patients. So early on, absolutely, I think it was the delivery of care. But then with time, we started to see some more of the medical impacts. And I think that was pretty surprising to us, because I don't think we'd been impacted in the same way.
Yeah, I'd have to agree with you wholeheartedly, Nikhil. And I think even further than just people being burnt out from having to deal with these very, very sick patients, we're seeing the effects of the Great Resignation as well. I would say when I talk to my colleagues around the country, we are all routinely being affected by nursing shortages, specifically in these very skilled nurses in cardiac intensive care units. We all do not have enough sonographers to do echoes for these patients. Every area seems to be affected. And we actually are at the point where we're having to close down beds because we don't have the staff to take care of patients. This to me is a really scary phenomenon that's going on. I think that we're all working together and working on ways that we can think outside of the box, have people practicing to the top of their licenses, looking for other care models to care for patients. But it is a very serious problem, I think, across the country right now.
I'm not sure that the public knows that, but do you know that from January onwards, we have such a shortage of nurses that everybody escapes to be flying nurses and travelers, and the difference in salary. I mean, you're talking about 4 or 5 times the amount of money if you're a traveler compared to somebody staying. I mean, in our hospital, we pay people to go beyond their regular 40 hours a week if they're able to do extra shift. We pay $1,500 a nurse to stay for 1 extra shift in the ICU. So the burgeoning costs make the situation absolutely unsustainable. And like Anne, I think that the pandemic will redefine a sector that was already under pressure. I think we will have to redefine the role of the nursing staff in healthcare, because we're not going to be able to sustain the situation like that for years.
Yeah, I think
one
all
of the things,
hospitals are bleeding. I'm sorry, Kayla. I think all hospitals are bleeding money here.
I was just saying, the other thing that I think is really important to note is when we're talking about wellness, we're talking about all this wellness that we're supposed to be doing within the workforce. It's really challenging to do wellness when people are just trying to survive. We're not even talking about wellness. We're not even there. We're talking about survival. And so trying to figure out a way to make things sustainable, try to find a way to make things equitable is the other part of this. Equitable care for individuals in the way that you deliver care, getting frustrated because you cannot deliver the care that you need to the various individuals because there's a shortage of beds, because everyone's in the emergency room waiting 9 hours is kind of the national average right now for waiting room for pediatric hospitals. So there's such downstream impacts of this obscene problem that it's profound.
What was challenging is our patients don't go away. So, congenital heart disease, if they're born with it, those neonates cannot wait. They need Dr. Uddicombe to operate in a very defined time period. So there was a lot of elective procedures. Absolutely, sure, you can defer some things, but if you have certain patients who have heart failure or need a heart transplant or need a certain neonatal operation, it cannot wait. And so whether or not you have the staff, you have to find the pieces to put it together. And I think one of the things was and I think everyone sort of locally adapted in their own way, but cardiac programs really couldn't change. Like we had to maintain the same volume, the same pace, and we maybe changed a little bit. Like our volumes were down maybe a touch, but honestly, we were not as impacted as some of our other subspecialists were, other specialists were. Because we couldn't.
Actually, but dovetailing off of that, Dr. Shani, I think people have a misperception about what the term elective surgery means.
Yes.
It's not necessarily elective in that it's like, a procedure for cosmetic reasons. That is not what we mean when we say elective surgery. I mean, I'm sure Dr. Dudick can speak to this, but it's something that's not emergent is maybe another way to say it, non-emergent surgeries as opposed to elective.
Until it becomes emergent, right? It's some of these things, you wait long enough and it's no longer just elective or non-emergent. Yeah.
Mm-hmm. And like Nikhil was saying, we have managed in pediatric cardiac surgery to get the cases through during the whole year. We did not postpone, we have specific timelines after which the results we're going to have from surgery will be worse or the surgery will be more dangerous. And so we've not gone beyond that point. We stretch as much as we could, but we've not gone beyond that point. But what we see, and it will be interesting to find out on the deeper effect of the pandemic, is like 50 to 70% of our staff are young people. And so we have lost an enormous amount of very precious nurses who have been working for 15, 20 years. And these are the people, and you realize that now, these are the people that were warranting safety of the surgery we're doing. And so I don't think it has vastly impacted outcomes in a way that is measurable, but I'd be curious to see.
Well, there's actually, been a couple interesting papers specifically out of cardiac units that have shown one of the number one predictors for avoiding whether it's cardiac arrest or outcomes is actually nursing experience more than almost anything else. And so if you lose that nursing experience, it will eventually have an impact.
Yeah, absolutely. And I'm sure as we head into winter, as many of you and your colleagues and other health experts have expressed concern about the triple demic, the triple threat of RSV, influenza, and COVID. And as many of you have mentioned, hospitals around the country are already facing bed shortages for those young patients on top of workforce shortages. So what are the implications or concerns that you have of this convergence of respiratory viruses as it relates to the outcomes of children's health?
Yeah, I would say that this is getting to be even more concerning because we're, at least out here in California, we are seeing the onset of this issue with RSV coming in and flu and COVID much earlier than we expected. I know that in Australia, they had a particularly bad flu year this last year, and which is kind of a prophecy for us of what we're to be expecting this year. But we are, I will tell you, in most of California, not to sound like an alarmist, there really are no more beds left. We are sending patients out of state as far as to Dr. Lopez's area in order to get our very critically ill patients taken care of. So this is, on top of not having enough beds to start with, and then having all these beds needed for other patients. From a cardiology standpoint, this is going to be a huge issue this year, I believe.
I'm still waiting from the message from my executive to go fishing, but it hasn't come yet. So I still go to work every day. But at some stage, they're going to tell me, go
It's
fishing.
coming. I think
but
it's coming.
But you can't, right? It's the same thing. You patients will still be born. They are still going to go into heart failure, and our hospitals impacted the same way. We're seeing volumes that we've never seen before. But to some extent, we have to protect our heart center has to remain protected a little bit because of these patients that just can't go anywhere. And, at least in Georgia, we're the only cardiac ICU for the whole state. So if you have a heart problem of any sort that needs ICU care, there's only one place to go in the entire state. So we really don't have a choice. We can't even send them elsewhere. And then when you start to think about their insurance status, many families, for personal reasons, for economic reasons, cannot leave the state. And so you have to find a way to take care of them and keep them in our unit. And so we're a little protected, but we see a spillover as well.
And that's what I was going to say, Shanley. That's part of the issue is that, if you're a patient who has Medicaid funding for your care, that funding does not cross state lines. So if you're in a situation where you cannot, in most cases, there's like a few states in which that's changing, but largely speaking, it's an access issue. So if you go to cross state lines, your Medicaid pays a third of what the Medicaid pays in the other state, and the other states tend to not like that and not accept that as a form of payment. That's one. The other thing is, our patients are not immune to having RSV and influenza and COVID. And so those types of things further delay their surgical care, because a lot of times people don't want to take them to the operating room if they have these respiratory infections. And so those are beds that are taken up. Those are kids that are really sick because they're in heart failure, they're over-circulated, have too much pulmonary blood flow. And so that is another bed issue because we're taking care of them. They need ICU care, but they haven't reached the point where we can actually do surgery on them yet.
And one interesting thing that is unveiling itself right now at the beginning of the as the winter is coming is that I had 2 weeks ago, I'm still taking calls, so I had to put 2 kids on ECMO who had previous cardiac surgery, who would never should have needed this ECMO, which is a cardiopulmonary circulatory support, from binal rhinoenterovirus conditions that are not supposed to get that sick. So the severity of the conditions we're going to see through the winter will be exceptionally harsh because they haven't been immunized. They haven't built up the immunity.
So you're taking children with terrible heart disease and then giving them terrible lung disease. And, usually you need one or the other, and it's a terrible combination.
That must be extremely concerning across the state. And as you all expressed, something that we need to address. So what is your message to the parents out there, the school teachers, everyone, in order to keep their children safe?
Keep your kids home if they're sick, first and foremost. Lots of hand washing.
Mm-hmm. Get vaccinated. I mean, the data is good for the flu vaccine. And there's no RSV vaccine. We do have a immunoglobulin, but at least for COVID and for influenza, it helps. It really does help. It mitigates for better or for worse. And, we've seen patients who have, especially immunocompromised patients, heart transplant patients who have not been vaccinated, who've suffered from it, and it's a tragedy because it's something that's preventable.
Mm-hmm.
I'm probably one of the few privileged to, if I may say so, to have operated patients because they needed cardiac surgery, patients in the middle of a COVID infection. I've seen it all. I promise you. I've seen trauma. I have never seen the amount of destruction of the lung tissue you get there. Unvaccinated patients, and I cannot conceive that if you see the image that you would want to, you would not want to get vaccinated.
The other thing I'll say is, please be careful of the source of your information surrounding vaccines, surrounding mitigation strategies, because there is a tremendous amount of disinformation and misinformation that exists on social media and other platforms. And so if you're going to be looking for answers, please look for answers in reputable sources, medical sources, medical websites that have probably more valid information, more accurate information regarding these vaccines.
Absolutely. And talking about COVID one more time, before COVID, childhood obesity was already a major health issue in the country. But according to a CDC report, the body mass index of children ages 2 to 19 nearly doubled during the pandemic. That must be concerning for people in your field. So as we think about risk factors for congenital heart disease and other heart conditions, what are the most important considerations for clinicians, public health officials, and parents when it comes to this issue?
I would say along with the obesity issue, but I think even more scary to me is the mental health we've seen. I think, in children with and without heart disease, we have seen a remarkable deterioration in behavioral and mental health. And unfortunately, historically, we have not done a great job as a society or as a culture to really take care of children with mental health disease. I think we're all trying to get better. I mean, I know Children's just announced a big partnership where they're building a whole behavioral mental health facility, but finding inpatient beds, finding care is a problem. And I know for most of us, all the patients that used to not survive that now survive still have development issues, have mental health issues. I think even more than anything else, that's come out of COVID as being a real problem.
I think at this point, it is imperative that as a field, that every child at every touch point, outpatient, inpatient, ICU, have social determinants of health screening to understand where this person is at in terms of what they're able to access, what kind of foods they can get, what kind of mental health services they can receive, where their mental health is right now. Because without understanding these things, telling someone to go home and just exercise more or something along those lines, when in actuality they're living in an area that is gang infested and dangerous, is unhelpful. And so as a field, we have to move towards understanding, meeting the patient where they are and screening for these things to try to better understand how we can intervene and what are the interventions that are possible. And that, of course, is an institutional and structural issue, at the local level, at the state level, that we need to work on.
Yeah, I would say that not only do we need to understand it, but I think it is going to be important as a country that we start dealing with these issues, not only for children who are obviously we're seeing the kids who are in the hospital are going home, the cardiac kids who need it, but this is a problem across the entire country for children. And children being one of the most vulnerable populations. And I think it's going to be important for us to start working on a national as well as local level on improving children's health by these really critical but very basic needs.
I'm curious, we're talking about at a national level and a local level, improving children's health strategies. I'm curious from your institutional or your individual institutions, what are you doing to improve children's health in that regard?
I'm sorry, I'll let you start.
Okay, I can tell you one thing is that coming from Australia, it was quite of a shock, I have to say, going to DC, and I'm sure you know how divided our population is in terms of demographic, to see the difference in access to healthcare and the way healthcare is perceived as well by the population. I mean, sometimes I had the feeling that, I was not far from the cops and the judges in their estimates, So what we have been doing is we committed to try to decrease the disparity in access to healthcare. And I give you an example. All I'm doing in my research is outcome research, and we know that depending on your socioeconomic background, the results of cardiac surgery are different. For the most severe condition, it's even more striking. And so we want not only to demonstrate that, but we want to look at access. So 25% of our population in the pediatric age in DC are lost to follow-up. All patients, if I select conditions where the patients need to get back to the cardiologist once a year, not benign condition where it's better, like they really need to get there. Well, 25% are lost. And we're in the first phase of a project, so we contact any other doctors who could have seen them and they haven't seen them. So we're going to approach and see them. The far-fetched project that we have is that if you two parents working at $13 and $17 an hour each 6 days a week, you're unlikely to have the time to take the appointments and organize your visits. So we have a bus in the hospital, and we'll see in the future if we can have the bus going to the communities and reaching them out, trying to find them where they are. And we're going to make studies to find out the barriers to access to healthcare. That's what we're going to try locally, at least in the terms of cardiac surgery. We have a lot of other programs in other disciplines in DC. So we have, branch of the hospital in the underserved community. So there's an easier access as well, generally speaking.
I think another major area is language access that can be difficult for people. And I think each of us work in a very different area of the country where there are different languages spoken. I think right now we personally have a task force that's really focused on making sure that we have language concordant with what our families are. And some of these languages can be very difficult to find people who actually speak. In the area that we are, there is a group of people who speak Triqui, and which is a indigenous language down in Mexico. We have often had situations where we have needed to translate 4 times over to get the point across to some of these families. And that's not optimal. There's no way that the information that I'm giving in English is going to end up in these patients' hands after it's had to go through 3 or 4 interpreters. And so we are trying to look for new ways of dealing with this and having people educated so that we can get much better translation services available to patients in this scenario. We also are working many of our institutions perform transplants. And I think that is an area that people definitely work hard to make sure that we have equity for patients across the board on who is being looked at for transplant and who is being accepted for transplant. But I think we are looking for new and novel ways of trying to align the transplant selection committee in such a way that we can actually even make that more equitable as well. There are a lot of social issues that go into whether or not someone will benefit from a transplant. And I think we are really working hard on trying to make sure that we have thought about those adequately.
There's a saying, if you build it, they will come, right? Well, they can't come unless they know how to get there. Yeah. And so if you don't have the built-in services, there's been a lot of perceptions regarding, for example, Latino populations and their lack of use of patient portals, their lack of use of telemedicine. Well, some of that is because they don't have the infrastructure to do that. But we just published a study showing that actually they are happy to use these services. They just don't know how. And so it's more than just saying, hey, you know what, we offer these services. There has to be some instruction at a literacy level that's appropriate for the various populations that we're serving. And, furthermore, as patients age, our patients are born with these conditions. They need ongoing care. They need repeated interventions. Often they sometimes will need later transplantation. And so the understanding for these populations of, guess what, your insurance is not guaranteed when you turn 18. And particularly in states where we don't have safety net or Medicaid expansion. And so having patients understand what they need to do, how they can stay on insurance and things like that are also really imperative to serving our populations. And so funding things like transition education, how do you transition appropriately and transfer to adult care appropriately, and having funding for those programs to teach patients things that doctors do not have time to discuss in the clinic. Things about skills, transition skills, how do I read an insurance card, basic things like this.
I think when most of us went into congenital heart disease, it was to take care of sick patients, not realizing that we as a group would get so good at taking care of sick patients that when they became sort of well, we would still need to continue to take care of them, but we were no longer giving them the resources or empowering them to continue to take care of themselves. And I think it's been probably for most of us, probably less so for Dr. Lopez, but I think for most, and as she said, came from outcomes to cardiology as opposed to cardiology to outcomes. I think most of us, it was very eye-opening last few years as we started to realize what that means. We did a study a few years ago where we realized the number one risk factor for a readmission after a neonatal heart operation was language, and that was why families, and that cost society, that cost the hospital, that cost the family to have to, and purely because we weren't discharging them with the appropriate language. And, that's a pretty simple intervention if you think about where all we have to do is sit down with an interpreter in the appropriate language. And lo and behold, we've avoided a readmission. We've saved the family a tremendous amount of stress and cost. We've saved the hospital. But someone has to think about it or has to ask the question or has to look. And I think that's one of the things we've realized, that we don't always have the tools or the resources to look. And I think part of what we've been trying to do is first establish what that infrastructure is. How do we even ask about race and ethnicity? It turns out none of our hospitals ask it the same way. In Canada, they weren't even allowed to ask what race or ethnicity you were. In fact, that was felt to be, racist to ask it. So they weren't even allowed to ask it up until a few years ago. We don't ask it the same way. So how do you even work together, collaborate when you're not even asking the same question? So first we have to start to ask these questions together, start working together to establish that. We've recently built a dashboard here at Children's, an equities dashboard, where we can, for all our patients, based on what they're admitted for, their DRG codes or procedure codes, we can map them geographically, race, ethnicity. But again, it's the way we capture race and ethnicity, it's actually not clear if it's being self-defined, if the admissions officer, if the bedside nurse is defining it. Haven't even clearly established that. So here we've built this great dashboard that shows us what lesions or what health problems are being impacted in different ways. But wait, are we even asking the right questions? Do we even know? And then you step aside, or you step broader than race and ethnicity. What about maternal education? We've seen there's a lot of good studies that shows maternal education can impact the health. We're not asking around that. Food deserts, do they have access to food? Are they in a safe neighborhood? So then they're starting to piece this apart based on geographic code. And so if you're born with this heart condition and you live in this zip code, what does that mean as opposed to this zip code? And so starting to look at that, then you can start to say, okay, this area of the state is at a higher risk for a readmission or has a higher death rate or a higher mortality rate. So maybe we need to see why and put an educator there or a social worker there, have a clinic that's closer. Telemedicine, I think we were forced to do it 2 years ago, but I think for a lot of us, it actually really empowered us. We were able to start reaching families in a way that we couldn't access before. And, almost every family has access to, whether it's a cell phone or something. And so at least you think, and so then you can start to reach them that way. One of the things, even from a follow-up standpoint, we started texting families, after a procedure, and just a simple text, a yes, no. If they didn't answer, we texted them again, and then we finally called them. All of a sudden, we could reach families for follow-up that we had never really reached before. So I think it's understanding, asking who they are, then what resources they have, and then meeting them where they are. Not even meeting them halfway, right? I don't think halfway is adequate. You have to meet them where they're at. I think we talk about, well, we need to meet them halfway. They can't even get halfway. You need to meet them where they are. And that's where you have to start to ask those questions, like, what do they have, so you can meet them there.
And I think, to expound on that a little bit, Nikhil, I think telemedicine has really kind of changed in a lot of ways the way we look at our patients.
Mm-hmm.
You bring a patient into the hospital, it's kind of, they're a generic patient, quote unquote, you don't really get to see where they're coming from, where they live, what the rest of their family is. And these telehealth visits, you get much more of a feeling for what your patient is experiencing on a day-to-day level. And it actually opens the eyes of the provider, I think, a whole lot more than what we've seen in the past.
And I'll say that given that race is a social construct, and that the health disparities that we see, quote unquote, based on race are directly due to systemic racism, what we need to do at the institutional level, really, and what, some of the things that we've done at Texas Children's in terms of implementing social determinants of health screening and things, that's where we really need to get to, some of the more upstream factors that end up causing these downstream outcome disparities. It is no longer, these disparities that we're seeing are directly due to the inequities in social determinants of health, which are directly due to systemic racism. And so this is why we need to do the screenings and understand what's the health literacy and understand what's the primary language and understand where do you live. Oh, you live in an area where it takes 2 buses to get here. Oh, your family has 1 car and you have 5 kids and someone has to work during your cardiology appointment. And so understanding those things really allow us to better serve the patients, the diverse patients that we have.
Absolutely. And Dr. Lopez, I understand since you are based in Houston, Texas, you have a very unique perspective on this, especially as we are so close to the border and as we have so many of the patient populations near the valley. Considering your primary research interests are on identifying those healthcare disparities among minority and underserved children, in Texas, where you're based, racial and ethnic disparities within the state's healthcare system really are among the worst in the nation. So I'm curious, what is the state of health inequity in Texas? What are you seeing? What are the driving factors behind it? And finally, what is TCH or Texas Children's doing to improve that?
Well, I can say that the state of things is profound. Inequities is profound. There's a lot of issues, again, at the upstream level that impacts our ability to deliver care at the institutional level. Things that, for example, Medicaid expansion. If there's Medicaid expansion, we have the ability to deliver care until the age of 21. If there's not, once you're 18, that's it. And so you invest so much money on the front end, these neonatal surgeries and these, ongoing repeated surgeries, and then only to say good luck to you, sorry about that. And so, some of the things that we've done at Texas Children's is that we are trying to build a place where individuals can have lifelong care. So we have actually the only in-person a unit dedicated to adult congenital heart disease patients. It's a unit just for them. They have a floor just for them. And so it's that alone trying to find, we have financial counselors just for them to try to find ways to deliver care to this very needy population who is surviving. They didn't used to survive, they survive now. And so we're trying to find ways to, again, meet the patients where they are. And while you can't do much at the institutional level to say, well, this is the hand that we were dealt in terms of Medicaid expansion, yes, no. What we can do is we can group together and advocate as subspecialists to say, this is inadequate care for individuals who used to die and are now surviving. And we need to think about how are we going to deliver this care across the lifespan, not just when they're children, because a lot of places, and Dr. Dudikin, I'm sure can speak to this, a lot of the places, the adult hospitals do not have surgeons that are trained in congenital heart disease to surgerize adults with congenital heart disease. And so a lot of those surgeries end up happening at children's hospitals. And so, and the outcomes have been proven to be better at children's hospitals, despite the fact that they're adults. And so there's a lot of resource allocation that needs to be looked at the state level, at the federal level. And there's a lot of advocacy work that needs to be done on our behalf as subspecialists to say our patients are surviving and we need to together advocate for improved care across the lifespan.
If I can give an example as well of the disparity, I was puzzled by something when I arrived here. You know that heart failure requiring assist device and heart transplantation, it's 40% in the pediatric age occur below the age of 1. And I don't know what Anne and Nikhil and Kayla are seeing, but that's not what I see here. Nobody, when I was in the UK, Germany, in Australia, that was the same. Belgium had an issue on that level, where I came from originally. But I don't see in DC 40% of the patients who have heart transplantation being less than 1. So there's a lack, and usually it signs the lack of access to primary health care. And so that's same than Nikhil, we're trying to identify the same way we have food desert, we're trying to identify areas which are desert for access to healthcare to see if we don't need to get there. I mean, locally, everybody has to do the work, I think.
Absolutely. And there's a lot of important, meaningful work being done at each of your institutions across the board. But I'd like to shift gears a little bit here and talk a little bit about the advancements and innovations being made at each of your institutions. Of course, there are surgical innovations and clinical innovations, but I'd like to start with Dr. Dudikum. As the Division Chief of Cardiac Surgery at Children's National, I understand there are some very exciting developments in surgical care, specifically in translating novel technologies into new approaches, devices, and treatments. What research and innovation is happening at your institution that excites you the most?
When it comes to cardiac surgery or any discipline whatsoever, you tend to say that it keeps progressing. Well, I can tell you in pediatric cardiac surgery, in the last 15 years, it has completely stalled. And we can talk about the involvement of the newest News and World Report scoring in that influence. But we have a field where in the last 15 years, there's no new operation. And the results for the most extreme condition, 2 ventricle or single ventricle, have stalled. There's no progress in the last 15 years. And so I think that the one of the few innovation that have happened now is the use by a little team, mainly by a little team in Florida and Gainesville, where they're doing single ventricle VAD. So they do mechanical circulatory support in a different way, without going into technical details, but to support tiny babies who have really the most extreme condition. And that has proven to be successful. So we've used that, we've pushed the envelope here. And we've used that to support in rescue situation, really extremely sick patients with quite a good success. Like 3/4 of them are going through, which is remarkable when you look at the patients. And that's one of the things why I went to North America, because I couldn't do these things in Australia. They wouldn't go, they wouldn't jump to these difficult operations. And I'm a firm believer for a long time in these assist device, and I think that that's going to change the face of what we're doing for the most extreme conditions where they're still, dying. We have some subset of conditions where we know that 90% of them will die within the first year of life. And so if you have time, if you had the small device, and that's one we're working on a PediaFlow, a tiny device, an AA battery, that you could live inside the heart. There's a little electrical wire, tiny, that goes out of the body. And imagine if you can, discharge this patient for 6 months to a year, the situation is completely different. So I'm very fond on, I think that's one of the areas of the future. The other avenue that I'm quite excited about, and I've learned by coming here, because they're operating here are babies much smaller and much sicker than they would ever approach in Europe or Australia. They would leave these babies to compassionate care. But one of my young colleagues has developed a very successful program for hybrid therapy. So we make a small operation where we keep the patient alive, but not repairing them, and we leave the repair later. And what I found with these hearts is that the heart goes through impressive changes just the first few weeks of life. You do one operation to a newborn that is 3.2 kilo at birth, and you do a shunt, the heart is loaded and blow up and dilate. You do the same operation in a patient that has waited for 8 weeks because he was 2.2 kilo. And at the same weight, you do the same operation, the heart does not distend. So there are changes happening the few last weeks of pregnancy, the first few weeks of life that we do not yet understand. You know salamander, and God knows, you would think that we're very far away from salamander. You cut the limb, in 40 days, the limb grows back. The same happens in mammals. If you chop the tip of the heart, the normal structured heart grows back. Up to 7 days of life, the mice keep that capacity. The piglets, 2 days of life. Humans, we don't know. So it's sure that there's a lot of things happening that we could use to remodel these hearts that we don't know about. And so that's our projects here. We'd like to focus on that very short period of life where so much happened in the heart.
That's incredible. And of course, not all conditions require surgical interventions. And that's why I'd like to toss this to Dr. Chinani and Dr. Dubin, as well as Dr. Lopez, on clinical innovation.
So all conditions need a heart operation. We agree on that, right?
It's funny you say that, because I was thinking that, one of the things we're pretty excited about is to try and put Dr. Dudicum out of business, and so, one of the things is like developing novel tissue methods to do, for example, valve replacement. We have a really nice partnership with Georgia Tech and Emory, similar to how Stanford has with Packard and Stanford, where we can really do a lot of tissue engineering. And one of the things they've been trying to do is like developing valves. One of the things a lot of our patients require heart surgery as babies or little children, and then they grow, but their valves don't grow. And so with time, they have to come back for repeated heart surgeries. So they go through the whole procedure all over again. As they get older, they start to remember it more. And then when you start to think about some of the things we were talking about earlier, where when they hit a certain age and they may not have insurance anymore, and they may not be able to afford that valve replacement. So then what can you do to avoid having to come back ever, right? If we can just do one surgery as a baby or maybe a second surgery and never come back, then that might actually help in so many different ways. And so one of the things we've been working on is actually trying to build valves. And how can you develop a valve that grows naturally and starts to take the place of these artificial valves and can be placed maybe in the cath lab or in the cardiac catheterization lab instead of in the operating room, so it's a little less traumatic. One of the things, as Dr. Dudicum was hinting at, is as we've gotten better, I realize, as he points out, in the last 15 years, we may not have had any surgical innovations, but if you look at our comprehensive care, we are pushing the envelope more. All of our centers are operating on smaller children. We're offering interventions to children we never would have considered when we were in training, whether it's from genetic abnormalities or other medical comorbidities. We now are offering procedures, but then that also means we have to take care of those other comorbidities. So for example, if they're born with an airway problem, let's say their trachea hasn't fully developed, so they're unable to breathe on their own, and they have a heart problem, we used to have to put in a tracheostomy. Now there's technology where we can design a custom built, polymer scaffold to surround the trachea and keep it open. So these children that we could never offer surgery to before, we can offer them surgery and then not even offer them a tracheostomy because we can support them with these scaffolds. So I think, as we're taking care of sicker children, we're developing other ways to deal with their other medical problems and then trying to find ways to avoid them having to come back to us. I think if they don't need to come back to the hospital, I think for families, for us, it's probably the best thing for them.
Absolutely. Yeah. And Dr. David, I see you nodding your head too.
Yeah, no, I would say that I think that I would absolutely agree with both what Dr. Dudicum and Dr. Chinani were just talking about. I think at Stanford, we are taking the approach of, as you said, surgery has kind of gone to the extent that they can go to as far as new and novel surgeries. We are doing things in smaller and smaller babies. But at the end of the day, many of the procedures that we end up doing, whether it be interventional or surgical, are palliations. They're not actual cures. And I think what we are aiming for, and this is kind of the long-term plan, is working with our basic science program, what we call our base science program, to actually build a totally new heart. And this is pretty exciting. Instead of just trying to build valves where we kind of place stem cells on these temporary scaffolding and then actually build a valve out of that, have these cells differentiate and become valve tissue, we actually are looking to build cardiac muscle. And we do that through a 3D printer. But it's really difficult. I mean, valves are doable because they're extremely thin layers of cells. For coming up with a true piece of myocardium, you need like millions of layers of cells, and it needs to be able to feed itself, and it needs to be able to differentiate into different types of cells. And Dr. Skylar Scott in our engineering group is well on his way to doing this. He has actually been able to build several of these organoids and have beating tissue that are a couple of millimeters thick, which is amazing. And I think his next step is actually to build these into a tube structure that we could use instead of what we use now for a Fontan procedure, not to get into too much detail. So it's like science fiction, how far things are going and have gotten. And so it's really exciting right now, I think, to be in the field, to be able to see this next level of development in general.
So he could put the transplant cardiologists and the surgeons out of business.
He's going to put everybody out of business. That's what I'm like. Why are we paying for him? He's going to put us all out of business in like 20 years.
Well, considering Dr. Dudicum is a leading expert in the Fontan procedure, you may be very well on your way to putting him out of business.
Nah, unfortunately or fortunately, I mean, he does such an amazing job with those cases. I think he'll have a job here for a while yet to come.
Yeah, because
I just
keep in
wanted
mind
to chime in.
these are great advances,
Oh,
but there has been I mean, these are far-fetched.
It's a long time coming. It's not happening for another 20 years.
I wanted to say one thing, as an imager, imaging is the bread and butter of our field. And so imaging has come a very long way in the last 20 years in terms of what we're able to do. There's been some advances in terms of understanding lymphatic channels. We used to never be able to do that, to understand who was going to be at a high risk for having increased output after surgery, of having chest tube output after surgery, and trying to map what that looks like and who's at a higher risk. We've also been able to do things like, Dr. Dubin talked about 3D imaging and all 3D imaging for surgical planning for very challenging cases. Also AI, so automation of our technology and imaging, and what we're able to do in terms of automating, perhaps in the prenatal space, who's getting prenatally diagnosed in places that they don't normally prenatally diagnose patients, because they have sonographers, for example, that are OB sonographers that are untrained, and having machines that can automate the detection of congenital heart disease. These are all things that have happened in the last decade that are really moving forward our ability to either identify congenital heart disease, or to intervene, or to plan for complex cases that were never possible before.
The one last thing, along with the technology, like, you're hearing about at all these institutions, the other thing that's been I thought really neat in the last few years is the interpersonal stuff and the training that we're doing a lot more of. Stanford does a lot of virtual reality stuff. We do a lot of simulation stuff. I know DC does a lot of stuff around cardiac arrest and prevention, and, all these things which can also help us take care of our patients and our research in a very different way, but things we just never thought about thinking, like, how do we practice the way we interact with the nurse? And that's both important for the patient, but also for nursing retention, right? As we talk about the great resignation, how do we keep staff and keep them engaged? So I think there's also been a change to some extent in how we value some of the other things that are not just at the bedside or patient related, but also our interpersonal stuff too. And I think that's been really nice to see too. Yeah.
There's two, if I may, there's two more things I want to highlight in terms of the things that are going to happen soon. I don't know if you've heard about the artificial womb, but I'm a believer. I think it's going to come on the market. So in 2 words, we're going to have premature baby delivered at up to even 22 weeks of gestation, being in a bag, not breathing air, but being like in a maternal environment with a placenta and connected to an oxygenator. That means that we're going to have access to these babies. I mean, they're connected to an oxygenator. I just have to put a pump and they're on bypass. And so in my mind, if we understand at what stage the heart develops, and I know that a lot of things are happening there, we're gonna have an opening to do a whole brand new range of operation. And I'm talking, that's something that will develop in the next 10 years, not end of the line. The other thing to join what Nikhil was saying is that we in a different environment than 20, 30 years ago. 20, 30 years ago, we were in the field of the pioneers. And there was an ego associated with it, and each center was fighting for its own reputation. And everybody was everybody was trying to be better than the other guys rather than just improve the whole field. There's a much more collaborative wave now between all institutions. We can gather numbers in a much wider way than in the past. And if we have a project, we're all good friends. I mean, it's working well, I think.
Well, and there's data that supports it.
Oh, sorry.
Oh, no. Go ahead, kid. Sorry.
I was going to say, to Dr. Jacob's point, do we actually have a network? It's called Cardiac Networks United. The whole purpose of this was founded on quality improvement efforts at the various institutions that then we said, you know what, this is not good enough. We have to join forces to look at this at a bigger level, at a larger level across institutions, to see if there are variations in practice, to see if there are variations in outcomes and what is driving those differences. And so there are at least 8 collaborations, at least, within Cardiac Networks United to help us kind of get at these bigger questions across institutions, to Dr. Judicum's point, being collaborative as opposed to competitive.
And I think it's more than just Cardiac Network United. I think many of the registries that we have kind of had blossom I mean, there are some issues with registries as far as the amount of manpower it takes to get good data into them. And that's a whole other, we don't have time for that topic today. But I think the general thought of these registries of where we are able to pool our results, look at best practice. There are many places that are now having learning networks, such as the Heart Failure Transplant Action Network, which is really a role model for many of our other subspecialties. And I think that probably if I had to have a crystal ball, I think in the next 10 years is really where we should leverage looking at quality and looking at research questions. I think that that is going to be where we're going to probably grow the most.
Absolutely. And certainly just keeping a look at the time, it looks like we do have 5 minutes, but we also have a couple of questions before we wrap up today's webinar. First, I'd like to start with one of our audience questions. Beyond what you've already shared, is there anything that non-clinical staff in cardiology can do to support the clinical staff to ensure our institutions are able to continue to provide quality care?
Just show up with a smile. I mean, I say that a bit, Joe, but it's been hard, right? We know for our non-clinical staff as well as our clinical staff, the last 2 years have been extraordinarily stressful, personally and professionally. And I think just coming in and being a team player right now is probably more than any of us could ask for. I mean, honestly, that goes a long way.
Anyone else like to add to that?
I think that's covers it.
I think personally, I think that we're gonna remodel care. I mean, I think we need new jobs. We need new specialties. There's a lot of the tasks that the nursing staff on the bedside that they're doing that can be done by somebody else, especially typing on a computer. And so we have to rethink the way we work. We need a deep remodeling of our healthcare models.
Mm-hmm.
Absolutely. And kind of piggybacking off of that healthcare question, beyond some of the Medicaid concerns, what are the ways that you and your colleagues in cardiology are trying to help young people transition into adolescence and adulthood? Dr. Lopez, I understand you are the director of the transition program at Texas Children's. So would you like to start?
Sure. There, like I think I mentioned this earlier, there's unfortunately not a lot of funding for this field. A lot of the funding doesn't exist. Reimbursement codes for transition education do not exist. There is a new code that just came out. It's a specific kind of code, but it remains to be seen whether or not that will be reimbursed under both private insurance and governmental insurance. A lot of times those codes that this falls under are not, unfortunately, yet. Those are the same codes that also, of course, code for social determinants of health, which are also not often reimbursed. And so that's is getting a reimbursement structure that works for transitioning from pediatric to adult care. But beyond that, we have found in our own program, we just actually reviewed the results of our program over the last 2 years to see if our program is making a difference. Not only is it making a difference for knowledge and transition skills, which is important as you're an adult with skills, but beyond that, it has also improved retention. We have found that by implementing our program, the rates of retention went from 29% to 86%. It is a profound change because people are understanding earlier the need to stay in care. And so that alone, from how do we do this, that alone should show that a program of this nature is necessary to improve longevity of care, to improve access or maintenance of care across the lifespan. Last thing is we're working on a transition mobile application to try to improve, to have a portable medical summary on your phone, to have access to tools and skills that you need to learn on your phone, to have an individualized app for your specific disease, to show the surgeries that you had, to show the interventions that you had, to have it be able to carry it instead of carrying a piece of paper, which is unrealistic in 2022.
Wonderful. Would anyone else like to add to that question? No? Well, it looks like our time is up. We are just wrapping up now. So before we end this call, does anyone have any final thoughts or calls to action before we conclude our discussion? I will
Go
take
vote.
that silence as a no.
Everyone should vote. It doesn't matter where, but just
Yep.
participate.
Good point. Vote.
That is a very, very good point. Well, wonderful. Thank you all for your time and valuable insight. This wraps up today's webinar. Thank you again.
Thank you so much.
Thank you.